Hello, everybody. Good evening, and welcome to another series of the talks on Facebook Live. We're here together with the Catherine McEwan Foundation, and as we've done throughout COVID-19 and the lockdown, we're coming together live tonight to answer your questions with very special guests with us tonight to try and help complement what we've already talked about. I'm delighted to welcome Janice Fennell and Charlie Lees. So I'll let Janice introduce herself first.
Thank you, Richard. I'm Janice Fennell. I'm one of the IBD nurses at the Western General, and I've been basically in the post for about 19 years, so quite a long time. We've got a great team by my side. We've got Joyce and Angus and James, and we've got Donald at St John's. So our role mainly is to support guys in terms of giving sort of advice, and I think this is very important, especially at this time, up-to-date advice, and therefore you to support you basically. So thank you for inviting me here tonight.
Thanks, Janice. The IBD nurses are very much in the front line and are there to answer questions first-hand from patients. I'd also like to introduce Charlie Lees. Charlie, just tell us a bit about yourself, please.
Yeah, well, good evening, everyone. Thanks for joining us. Those of you who are in Scotland, it's a rare bluebird evening, so if you're joining us live, then thank you very much. I think the forecast is set to be good for the next week. I was just saying to Richard and Janice before, I'm optimistic that all the sunlight and the UV is going to burn away all the COVID. So I'm here to give an optimistic note about where we're at and where we're going forwards, I hope. So who am I? I'm a gastroenterologist and an academic here at the Edinburgh IBD unit, where we now have Richard and Janice, of course, who's just introduced herself, running the IBD nursing team. So what's important for me to say about myself? Well, I'm a practicing gastroenterologist. We run a very busy IBD service in Edinburgh. We now know actually that in Edinburgh there are about 8,000 people living with inflammatory bowel disease, and in a population of just over 800,000 people in Lothian, that gives the prevalence rate, the current number of people in Edinburgh living with IBD is 0.78%. It's about 1 in 125 people. It's quite extraordinary when you think about it. And actually, we've mapped this out with Scottish population data that shows that will go past 1% within a decade. People are getting older. That's just a fact of life. And we're diagnosing people with inflammatory bowel disease at all ages, but still mostly when they are young. So there's a lot of work for us to do. There's a lot of patients for us to look after. And we'll talk a little bit, I think, as we go along about some of the challenges that we faced during COVID because of this. But actually, I hope that what I'll be able to show you a little bit as well is that we're innovating as we go.
Thank you very, very much. So we have two experts with a long experience and looking after a big population of patients with IBD. Please give us your questions. We're here to answer the questions as best we can. We don't know all of the answers to all of the questions, but we'll do our very best. Just while you're thinking of those questions, Charlie has very kindly agreed to give us an update just as to where things are with COVID at present, and you should be able to see those slides just with his talk for 5 minutes or so, and then we'll go to the question and answer session.
Okay, John. Great. So the first picture that I'm just going to show you now is a schematic of this ghastly virus. It's a tiny wee thing. It really is, but it's full up on your screen there, and it's got these red bits that stick out of it. This called the spike protein, and that's quite important. So, John, if you move on to the next slide, where we've got a couple of definitions on here. So I just wanted to make sure we know what we're talking about. So SARS-CoV-2, what is this? So we know about SARS. SARS is severe acute respiratory syndrome, and this was SARS-1 that caused such a problem about a decade ago. The COV just means it's a coronavirus, and 2, this is the second big one. And COVID-19 is the disease that comes from the virus. So across the British media in particular, we've learned about coronavirus. That's the SARS-CoV-2 is the type of coronavirus that causes this COVID disease. And the virus enters through the nose, the mouth, the eyes, and that's why it's so important not to touch our face, which is quite difficult. It's also why it's so important that we wash our hands, because soap kills the virus. So if we wash our hands well, we kill the virus, stops it getting into our face. And there is lots of this receptor, the ACE2 receptor in the nose. And it's quite interesting, actually, because recently they've shown that kids have much lower levels of this ACE2 receptor in the nose, which is probably partly why they're so protected. But for us as gastroenterologists, it's interesting because there's lots of this ACE2 receptor in the gut, in the small bowel and in the large bowel. And we found that the virus is present in the stool, although we're still not quite sure whether or not the virus in the stool is important, because it looks like it might be inert. But what we do know is that there are quite a lot of patients that present with gut symptoms as a presenting symptom for their COVID. And so when we're looking after with IBD, that's quite important. So we've got to try and work out our symptoms related to COVID or to a flare of IBD, for example. So John, if you move on to my timeline, I wanted just to orientate people just to what's gone on. I think that if you're like me, the time, all sense of time seems to have gone out the window. It's almost impossible to remember what happened before. Bear in mind that it was the 31st of December when anyone outside of China knew anything about COVID-19. You can look at the timelines across here. January the 30th was the first UK case. Shutdown begins 21st of March. And then, amazingly, already 8th of April, Wuhan lifting its travel restrictions. John, go to my next timeline for me, if you can, whilst you're eating your dinner. And this just shows some more of the British events that we have on here. And more specifically, I think just looking at some of the things that happened from our perspective. I convened a UK group on the 16th of March, got onto WhatsApp, messaged a few of my mates, and by the end of that week, we had 80 of us on a WhatsApp group talking about how we would manage this. And I'll just give you a brief insight into a couple of things that we discussed. And so what I'll ask you to do, John, is just move on next. So that's on to the slide that says COVID, coronavirus, guidance and advice. Great. So the aim that we had throughout all of this, right from the very start, was to do our very best to provide advice that will allow us to keep people with IBD well, safe, and out of hospital. Why? Because we wanted to stop the disease from flaring, so we didn't need to use steroids, because right from the start we were worried about the potential risk of steroids. We wanted to keep people out of hospital where there might be, and there probably would be, more exposure, more risk of COVID, but we also wanted to be able to treat flares rapidly and provide care for new patients. So this took a lot of service redeployment. Janice and the nursing team were critically involved with all of this. We wanted to maintain the team when there were real threats of sickness and redeployment. A consultant-led service. We set up a new flare clinic that we've been running daily. We've done a lot of, I think, quite innovative things. We've virtualized our working with daily huddles every morning to discuss urgent cases via Zoom. And at the same time, we've had to deal with not being able to offer face-to-face consultations. So I'm sure we'll come back to that in the Q&A. That's been a real challenge for us. Most of it's been picking up the phone, which has been good as a stopgap, but we're now increasingly using video consultations. And we might discuss a bit later on, Richard, about how that is from the patient perspective too. It'd be very interesting to hear that. We've had challenges because of endoscopy being suspended. And again, we might touch on that a bit later on, but there are 2 or 3 major reasons for that. The first was that endoscopy is very, very intensive on PPE, the personal protective equipment. And so we had to partly to conserve supplies. And those in Edinburgh will know that we had to move the infusion suite. It was possible we were going to have to move it twice, but we've so far only moved it once. And the team there have done a fantastic job keeping that manned. All right, let's move on. So I don't want to speak for too long. So move on to the next, just some very basic principles. So we wanted to keep people safe, out of hospital. We wanted to keep people on the medicines. And anyone that's listened to me harp on about stuff on Twitter or on Instagram or YouTube or anywhere else, that's been one of the key messages. Stay on your drugs, stop the disease from flaring, stop the need to have steroids or be hospitalized or need to have an operation or anything across the piece. And as we have learned more and more, we have learned that by and large, IBD drugs appear to be safe. They don't appear to have any increased risk, with the exception of corticosteroids. So we're still using prednisolone when we need to, but we're avoiding it as where we possibly can, because there perhaps is an increased risk there. And you'll see just some of these other things: managing disease flares, using telemedicine, monitoring, communication, maintaining the effective team, and building resilience. And I think this is a really important thing. A couple more points before I finish. The next slide, John, is the dreaded risk grid, which we thought a lot about. And actually, I think we got this just about right. I don't want to talk too much about shielding just now, because I think we'll talk about that a bit later on. We've been very wary about not instructing shielding unnecessarily. We've tried to follow as much of the guidance that was coming through about the real risks of this virus. And what have we learned? We've learned that older people, men, people who are obese, people with diabetes and other chronic conditions appear to be much more at increased risk. And people with bowel disease do not necessarily appear to be at increased risk. So this is important. We do need to keep some concerns about people who've got active disease, people who are on multiple drugs, and particularly steroids. But the risk grid, I think, by and large, helped us get around that. A couple more minutes, Richard. Next, John, if you move on, I just wanted to flag this slide that I put up on Twitter yesterday. This is something I wrote about a month or so ago about collateral damage from COVID. We are now starting to move through into the mid and longer term phases. And really, it's the bottom part of this that I want to draw your attention to. And that is the stress and the fatigue and the psychosocial problems and the mental health concerns that we're seeing starting to emerge, and something that I want to be very, very mindful of as we move forwards, so that everyone is aware that this has been a difficult time for everyone, and for people who are living with a chronic illness, particularly one that can be so intrusive and difficult, bowel disease, really very important indeed. So I'm going to finish by going through the top 10 tips that we wrote 2 months ago that actually I went through again this morning. I think it's still really it is relevant. But do everything we can to keep people safe and well during COVID-19. Don't stop your medicines. Preventing disease flares is a priority. Number 3, we're on to the top tips, John. Yeah. So when we moved on. We'll keep you well. Don't stop your medicines. Ensure you have a good supply of your medicines. Wash your hands. Contact your team if you have a flare. Work from home if possible. This is moving on now, of course. And the smoking thing has moved on as well. Not smoking is a good thing generally, but it probably doesn't increase the risk of COVID, which is a weird thing. And finally, John, if you move on to the second half of this, it just goes through the rest of the top 10 tips. And I just want to finish, Richard, with tip 10. Take care of yourself, but also be kind and considerate to others in these difficult times. And I think that now applies more than ever, as lots of different people will have had very, very different experiences for the last 2 months. And I think it's really important that we don't presume the kind of experience anyone has had. Some people will have had a jolly nice time. Other people will have had a torrid time and suffered in silence. And I think it's really tantamount important that we all bear that in mind. So, Richard.
Charlie, thank you very much, and thank you for everyone who's bringing the questions in. Charlie, it's really helpful to have an update and sharing the experience from the start of this pandemic right through to where we are now, and a lot of the questions which are coming in really reflect, what's going to happen next. So I'd like to thank everybody who's started with their questions, but please do keep them coming in. Janice and Charlie, the first question is from one of your patients, actually, and they're really asking about next day. So, can vulnerable people keep uncomfortable people keep safe after lockdown is lifted? Can we sit at the recommended distance with family in a shared garden? This is a patient who's on Humira and mercaptopurine. So either of you, who'd like to start first? Janice, this could be a call that we've saved to the helpline tomorrow.
So you're on mercaptopurine and adalimumab. It really depends on your risk category. If it's obviously, if you're within the moderate category, as you don't have a current active disease or any other comorbidity, or obviously if you're under 70, then I suppose you would be in the moderate risk category. And I think we all still, COVID's not gone away. It's still here. Even though we are easing, hopefully easing things come Friday. So, the decision to obviously meet other people, but keep socially distanced, it's a personal decision, and, you've got to really still remain vigilant, but as Charlie said, we really need to think about, our emotional well-being as well. And it would be nice to, meet family or friends, within a certain distance and in a green space. So yeah, if you're within that moderate risk category, then yes. Unfortunately, if you're still shielding, the advice stands, and we would certainly recommend that you continue to do so. I think, would you agree with that, Charlie?
Absolutely, Janice. That was actually spot on. This has always been a dynamic situation. It remains one. And we will do the best we can to update the guidance based on as thorough a review of the literature and the evidence as we possibly are able to, with a caveat that we are also slightly betrothed to national guidance that differs across England and Scotland, for example, already. Having said that, the guidance, we do hope that we're moving out of this initial phase of lockdown in Scotland, at least, as you say, from the end of this week. I think there is always going to be an element of personal responsibility for everyone to work out what level of risk that they are happy to go with. I think the risk grid still stands as in terms of our advice in terms of what risk an individual person has. I hope that we will be moving to lift shielding instructions for most people quite soon, because I really think it's important that people can be able to have social interactions, albeit maintaining social distance. And I think, if I just finish on the answer to this on this point, it really is clear that, if you go and have a social distance walk with someone and you're 2 meters apart, your risk of catching coronavirus is probably very, very low, particularly outside. If you go and have a cup of tea and sit, opposite table to someone and have dinner with someone, your risk of catching coronavirus is probably much higher. So, socially distanced walks, for example, I think will be a great place to start from that perspective.
Okay, thanks very much for very thorough answers, both of you. A related question, Helen Lindsay, I'm not ignoring yours, I'm coming back to it, but Natasha Mann has asked us, thank you very much, when does shielding end? I thought it was the 18th of June in Scotland, is that right? Or
I think there's a review promised on the 11th of June. We have, and we don't know yet, there's a review, does that mean shielding is going to end or not? So we're having a conflab of all the different people involved, the British Society of Gastroenterology, next week to review the guidance so that we can provide the updated advice, so that if the Public Health England and the Scottish Government say all those who are shielding continue to shield, we can then look to see whether or not we change who is in the highest risk group.
Yeah, I think within, if there's any parents listening, we are really trying to restrict the number of children who are shielded, because we recognise, particularly for teenagers, it's very hard. And because of children's younger age, probably there are less children who need to shield compared to older adults with inflammatory bowel disease. Charlie, this is Well, Charlie and Janice, this is one for you. Unrelated to COVID, can a food allergy affect your Crohn's disease? That one's from Helen Lindsay.
Diet as a whole is a fascinating area for us, and as you know, something that we're studying actively at the moment.
We did have a whole Facebook Live on it last week, Charlie.
Did you?
Yes, we did.
I'm sorry I missed it. So then I'll give a short answer, which is that I don't think a food allergy per se affects most people's Crohn's disease, but I think there is no doubt that different people have different intolerances to food that can exacerbate their gut symptoms, some of which are not necessarily specifically Crohn's derived, but others that might be. This is the short answer.
Okay, Janice, do you have anything to add to that? Lots of patients are
I speak to patients all the time who know that there are certain triggers for them, and it's definite food categories, but unless they're formally tested, we would just call it an intolerance rather than an actual allergy. But patients know their own bodies and they know what upsets them, and so we would advise them if it's not a full group of foods, that they just be sensible and just cut them out, just to help with their symptoms.
I would just add, just very quickly, I would encourage people not to go and spend money on getting food allergy tests. The vast majority of them are a complete waste of time and waste of money.
Unless it's for celiac disease, which does run a bit higher with IBD. That's our only caveat. Okay. Kathleen Bone, thank you very much for your question. This is an excellent question, actually. Do we know the reliability of the approved antibody test, and will it be affected if you're on IBD drugs like azathioprine?
Yeah, what a good question. We don't know the answer to that specific question. So there are two types of tests for COVID, basically. One is a PCR-based test. This is a test where you look to see if you can sequence some of the virus's own genome in a PCR test. And they're actually somewhat inaccurate. They're about 70% accurate, assuming that you've done the best test that you can. The antibody tests that we now have available in the UK, and I think there are at least two commercially available ones, one from Abbott and one from Roche, that have accuracies that are certainly in excess of 95% and probably even higher than that. And they are accurate if you have had the virus and developed an antibody response to it. And would that antibody response be affected by IBD drugs? It's possible, but we don't know. And it's something that there is a bit of study going on to look at, in fact, from groups in Imperial and Exeter later this year. I guess the final bit about that is there's some emerging evidence of different types of antibody-mediated immunity, T-cell immunity to the virus. And if that's the case with cross-reactivity to common cold coronaviruses, so there are coronaviruses that cause nasty COVID and the coronaviruses that cause the common cold. And it might just be that if we were able to measure the totality of that immunity across standard immunity, that the immunoglobulins that we currently pick up in the antibody test plus T-cell immunity, that more of the population may be protected. And that might be why things are going down quickly.
Charlie, you're going a bit sciencey on everybody.
We're all learning something tonight.
We're all learning, that's right. A great question from Janice Hicks. If the other two don't mind, I will just answer this quickly. How can I ensure I don't pass the virus on to my daughter, who's age 11, with Crohn's disease on azathioprine? Well, your daughter is a medium to low risk, and you just need to take the same precautions as Charlie has talked about earlier. So very good hand hygiene, very aware if anybody becomes ill, and any concerns, share them with your IBD team. But just really following very strictly the government's guidance is the best thing to do. Next question here. The questions are really of high quality. June Smith has asked us, how does COVID-19 affect the GI system, and how what is its long-term effect?
Yeah. So most people with COVID don't get any GI system effects or symptoms. Some people do. Some people present just with pain, but it's rather more common that people present with diarrheal symptoms, which could be very similar to, a flare-up of Crohn's disease, for example. There has been evidence that the virus can be detected in poo. I'll keep it less sciencey for you, Richard, for quite some time after COVID, but we don't know what the relevance of that is. The second part of that question is, what are the long-term effects? Well, I think we do now know that most people who get bad COVID, who are in hospital, have quite a prolonged recovery. Most of those effects are probably on the lung, particularly if people have unfortunately ended up needing to be ventilated. But for other people, the effects on nutrition, probably more than anything, can be quite profound. Quite a lot of people, quite a lot of colleagues in London who got COVID said to me that one of the things that they really noticed, apart from the loss of smell, was they had zero appetite at all for a couple of weeks, and they lost quite considerable amounts of weight. So I think if you know anyone that's had COVID, be kind to them for quite some time, because they might, well, be kind to them anyway, but they may well be having quite a protracted recovery.
Okay, the next question is really, I think, a very important one. So I'd like you both just to spend a little time to answer it, please, because this is a question I think over the past 2 months we've heard recurrently. So Jennifer Rackman, thank you very much. She has a question about shielding. So she's on azathioprine, she has colitis, and she's had a letter from the Scottish Government to say she should be shielding. However, when she looks at the IBD risk grid on the Crohn's and colitis website, it says she's moderate risk and she doesn't need to be shielding. She says she's very confused and would like advice. So I think, we've all had this question a lot. Would you like to give Jennifer, and I'm sure many other people listening who want to ask the same question, good advice, please?
I've had quite a few calls through to our advice line with that very question. Patients who have been categorised wrongly, I suppose, but I think the data initially was from various databases from GPs, and obviously patients are changing their meds all the time, so those databases were maybe not updated, so patients have received shielding letters when maybe obviously they're not all shielding, so the right thing to do is to check, obviously, to get advice from your IBD hospital, your IBD service, and talk it through with us, because obviously you are moderate risk category if you're on azathioprine with UC. But obviously, if you have the other comorbidities, or you are flaring, then there is some discussion needed there as to where you're at. So because you can change from one category, and back again. So just depending on how your disease is in terms of flaring. So yeah, it's my advice is to get in touch with your IBD nurse and discuss it further and get reassurances.
So Janice, I didn't give you the whole question, but Jennifer did say that she doesn't have any of the other risk factors, right, and she's well just now. So okay. I think she would be in the non-shielding category probably. Charlie, what would you like to add to that?
That was an excellent answer. Thank you, Janice. I think I would first start by saying that I definitely recognise the stress and anxiety that is caused by conflicting advice about something so important as shielding. I think it has caused disproportionate amount of anxiety. We have been really careful to try and give very careful, clear messaging, and we have at times been battling against public health bodies doing slightly their own thing. To give some context to that, the very first message we got about this was that they were going to put down a blanket advice that anyone taking any immune suppressant drug So that would be anyone on azathioprine or anyone, any biological methotrexate was to go in the shielding group. So we moved a long way from that to, I think, what was very sensible advice. I won't go through everything that Janice so eloquently said before, but what I would just say is that there are two, what I would say, gospels of truth here, and the advice is to follow them. First is the Crohn's and colitis UK risk tool that allows you to go through their decision tree and work out what group you're in. Secondly is the IBD registry tool, which you can find by going into your internet browser and typing in ibdregistry.org.uk/COVID-19, and that's COVID-19 with a hyphen. There is then a blue bar banner. Click here to access the COVID-19 UK IBD tool. That then allows you to go through and answer a number of questions, takes 3 or 4 minutes with all the appropriate data privacy and security that you might want, and a whole lot more. This has been painstakingly put through all the relevant digital privacy systems, and then you will be told what risk group you are in. And if you're in the highest risk group or any group, you are able to then print out this that then allows you to have certification to take to your employer, which is often one of the things that has come out. Janice indicated, and it's a really important thing to bear in mind, that IBD is dynamic. It's not like someone who just has a solid organ transplant, for example, which is where a lot of the governmental advice was coming from. So you can move in and out of different categories. And so if you go to the risk tool, you can have certification at any point along the way. The advantage of inputting your data into that tool as well is it allows us to then contact you if the advice changes, were we to find a significant shift based on the data that's being collected across the world, which I'm pleased to say that we have not. So yes, it's something that causes a lot of stress. We appreciate this, but the letters unfortunately have often been wrong, and the gospels of truth are the risk tool, ibdregistry.org.uk/COVID-19 with a hyphen, or the Crohn's and Colitis UK decision tree.
Thanks very much both for your detailed answers, and I think it was worth just spending a bit of time on that, because I think one of the values of having a session like this is exactly to talk through questions like that. I'm going to just give you a couple of quick questions and quick answers. Janice, this is a very practical one, but I'm not sure how easy it is to answer. So thank you, Fiona Borthwick. What's the risk from public toilets, as patients with IBD are more likely to use these than the general public?
I suppose if it was me, I would probably want to minimize my risk and avoid them. But obviously the nature of IBD and, the debilitation in terms of needing to go quickly whilst out and about needs masks. I mean, you need to carry sort of hand gels and wipes, and, they might not even have soap in the public toilets. So again, it's just carrying your own stuff with you when we ease lockdown and you need to visit a public toilet. It's be prepared is my quick answer.
Yeah, I want to add to this. I think this is a really, really good question, actually, because it opens up all sorts of issues. First and foremost, I bet you can't find the public toilet that's open right now. I bet most of them are shut. So if you are out and about, that will cause real problems, and they're probably overcrowded. So, normally I would have said don't worry about it, but now, I think being prepared is relevant. And I really worry, actually, for post-COVID, that people with IBD will find it harder to access public toilets because more and more of them will be closed for whatever reason. So I think we have to work out a solution to that. I have for a while wanted to build a proper toilet tracking app so that people with IBD could find toilets and have a socially crowded system that would allow you to find out which ones are open, what the code is, whether or not they're kept clean or not, whether or not the soap or, these kinds of things. So it's a relatively simple thing to build. So if anyone wants to help us build that, let us know, and we'll get on and do it.
So a toilet app with ratings, I would say, sounds like a very practical outcome from this. Charlie, a quick question from you, from Janice, but not Janice Fennell, obviously. If they do find a vaccine, will it be a live one?
So there are, I think, at least 10. There are lots and lots of vaccines in development. There are at least 10 that are being tested quite significantly, and I think, from the top of my head, there are about 4 or 5 different types of vaccine being trialed. Most of them are not live, but there are all sorts of different types of vaccine that are being used. I'm not a vaccine expert, but I hope that they're not. I don't think there should be any problem with people on immunosuppressants getting the vaccine, which I guess is what the question is coming about from. And I very much hope that there will be enough vaccine produced in enough quantities quickly enough so that everyone with IBD can get them. And I hope that someone manages to silence all the pesky anti-vaxxers out there, because this is probably our way out of this for the good, for the future.
Yeah, I agree with that. And I'm sure everybody knows that the vaccine trials are ongoing all across the UK. We have people from outside Scotland tuning in tonight. So it's a real UK effort to try and find the vaccine, and including here in Lothian, the first vaccine trials are being done with staff from Lothian Health Board, frontline workers who are exposed. So they start very soon, actually.
Yesterday.
So soon it's passed. So this is a question from Colette Egan. Thanks very much. What are the next steps after shielding? How can we protect our vulnerable children with IBD without affecting mental health even more, to see grandparents and others? So I think, Charlie, you covered this point very well just in your top 10 tips towards the end. I think, one of the clear messages we have so far is that IBD in general, aside from what Charlie said, does not seem like a higher risk category than some of the other chronic diseases. And particularly for children, they are not more vulnerable. In fact, they're the opposite. So young children have a very, very low risk. So actually, the children will not be the vulnerable ones. It will be the adults or the grandparents that they're in contact with. I think as soon as we can start to work out how we can decrease shielding, and the Royal College of Paediatrics, who gives us guidance for all children's health in the UK, is about to produce some more guidance this week, which will really reduce the number of children who are shielding even more. So we've had very few children, thankfully, we've had to shield with Crohn's disease and colitis, less than 4% of the children that we look after, and I expect that to fall soon to an even smaller amount. So lots of people are asking when shielding ends. I think, Charlie, you've already answered that and say we don't really know. We know when shielding's up for review, but I think probably what we would agree on is shielding as it is now may change slightly as we go forward, and the number of people shielding may reduce rather than increase.
Yeah, I think just to reassure people again that we are looking as best we can into all the data that is available. It is staggering just how much clinical and scientific data is being produced and published around COVID from all around the world. Bear in mind, we're learning not just from Edinburgh, Scotland and across the UK, we're learning from everyone across the world who's unfortunately had to deal with this. IBD is global, so we have a very good network, a very good family of colleagues and friends working in the hospitals and in the labs across the place, and we're sharing data to try and make most sense of that. So I hope that we can review all of that evidence together and come to some sensible advice and have fewer people shielding as soon as possible.
Janice and Charlie, lots of people are saying very nice things about you, particularly just talking about some of the arrangements for the infusion suite and things, and very positive about all the measures that have been put in there to make them feel safe as they get their infusion. So very helpful feedback. Ruth Wilson.
Tell people, Janice, what we did, just in terms of the things that people have done in the infusion suite.
Yeah, I mean,
we've done quite a lot of great work there.
I think quite swiftly the infusion staff moved a whole unit to a safe green area, and you know, obviously it was just, they had like a couple of hours to move because they had infusions the next day, and they're doing a sterling job there in terms of their strict hygiene measures, and wiping everything that stands still every in between patients. Patients are they're 2 meters apart from each other. There's obviously PPI there, the surgical masks, and they're being phoned to make sure that they don't have any symptoms prior to coming in. So yeah, I must admit I'm very impressed as to how they've continued to run the service so sleekly. And
I remember going in on the first day, and we just almost the first week of this, and we went in and physically removed 2 or 3 of the chairs and put them out. Took all the waiting chairs out and banned all the relatives. Literally that first day going around with you and Pauline and others.
Yeah, we had a few patients who decided that, they were back in March. Everyone was frightened and scared, and lots of people decided, I don't want my treatment. But obviously the message got out that that was the best thing to do is to continue on your treatment. We need to keep you well. We need to keep you out of hospital. So so it's back on track again, and most people have got that message.
People are continue asking questions about shielding, obviously a very important area. Ruth Wilson has asked us about who actually knows about shielding. So she didn't get a letter from the hospital, but she did get a letter from her local council, and she's asked who gave the council that information. So Charlie, do you want to talk through the process of how people are identified?
Yeah, it was complicated, and the honest answer is it's been done 2 or 3 times in some areas. So there has been, in Scotland, there was an exercise done based on the data that Scotland holds about people based on disease classifications, and otherwise we were asked to identify people who met the shielding criteria and to pass that information on. But yeah, I appreciate it's been difficult and contentious. I would be interested to know if any people are concerned about not being put into the shielding group and they thought they should be, and therefore not getting support that they felt they might have needed, because that was one of the reasons for making sure we got this right, was because initially we weren't sure what was going to be given from the government to people in the shielding group. I think most people get a box of food once a week.
Only if you ask for it.
If you ask for it, yeah.
So related question, Jacqueline Grant, my 13-year-old started infliximab infusions almost 4 weeks ago and is also on azathioprine. He's shielding, but what happens when his brothers have to return to school? What's the risk for my son? Our husband is a taxi driver and is staying home, so we don't know what we should do. I guess there's a general principle here about other family members and what they do if somebody's shielding, and also coming back to how long a person should shield. So do you both want to try and answer that question as a general point?
I mean, I certainly think that, you need to continue to, I suppose, shield within your household in terms of when coming from work, having a shower, wiping down your phone, your keys, just being sensible and within your household in terms of if you can sort of share, if you've got a separate toilet or bathroom, obviously the person shielding needs to make sure that they take safeguard there and use separate towels. And I know it's very difficult in these situations, not just physically but psychologically, to be disconnected from your household, from your family. But at the moment, this is the advice that the government are giving in terms of the shielding advice. So it's It's a hard one, a tough one.
So I've just a couple of specifics and then a couple of general points then. So this is a young person, so the general risk is low. The risk of active disease is presumably why this person's then been started on infliximab. So we are looking, so that's why there's some advice about the initial phases whilst on a new drug therapy, and that then changes and then allows to move along. And I would say that, as soon as, the drug starts to work, then that reduces the risk quite significantly. I think in terms of the general points, Janice covers them really, really nicely. There's a couple of things. Washing your hands makes a massive difference. It really does. And one of the things that has been very badly reported, but it's fantastic, is that the influenza season this year finished really early compared to normal years. And it's probably because everyone's washing their hands properly, it stopped influenza spreading around. So hand hygiene is really very, very important. And then it's just remember, what does this virus like? The virus likes skin. It likes it if you touch your face, and it likes it if you're in a closed environment close to someone. So that's why if you're indoors and you're within a meter of someone, then there's quite a large chance of the virus transmitting. And it quite likes surfaces at that. But if you're outside, socially distanced, then I think the risks are much lower. There's evidence that UV kills the virus. It's very hard to see it spreading outside. We're not seeing any significant clusters from all the outside activity that's reported. So get outside, enjoy the sunshine if you can, is my advice.
Okay. The only caveat I would add into that is, so the shielding for your child will only be there for the first 6 weeks as long as they respond to the infliximab. So as Charlie made the point before, unlike if you've had a liver or a kidney transplant, the shielding doesn't necessarily last for 12 weeks or longer. Once you've got better and are stable on your medicines, then you can probably come out of the shielding category. We have not long left, and we have loads and loads of questions to get through. So I'm going to ask you just if we can try and cover. I apologise to everyone if I can't answer all your questions specifically. I'm going to just pick some out just for some quick answers. So first one, Charlie, from Fiona Borthwick, thank you. Are we more at risk from cytokine storms? Having experienced multiple flares but being in remission, I'm low risk but don't want to push it. No evidence you're increased risk for cytokine storm, and perhaps some of the drugs that we have our patients on will help protect against them. There are, just very briefly, there are a number of studies looking at some of the drugs that we use to treat cytokine storm, ranging from infliximab to adalimumab to tofacitinib. So I think no is the answer. Okay. Should someone who has a stoma and they're due flu vaccines or other vaccines be at increased risk of complications? No. A question from Susie Lynch. I'm on prednisolone and have 5 weeks left of the course. Should I still be shielding after this? Janice, do you want to take that?
Well, not unless, it depends what else. If the patient's obviously not on any other immunosuppressant or haven't got comorbidities that are obviously listed or are obviously over 70.
20 milligrams of prednisolone is the magic number. So as soon as you get below 20 milligrams of prednisolone, your risk drops. And that's been noted across all the immune diseases like rheumatology, rheumatoid arthritis, etc. So when you get to 15 milligrams, you can stop shielding. Unless you're a very light child under the age of 12, and then the dose might be lower. But a question from Mandy Kerr. I am shielding using tofacitinib. Can I return to work after the 30th of June? Yeah, I think that's going to be one that's to look at specifically, depending on a number of devices and depending on where you work, etc. If your disease is well controlled, yes, I wouldn't go back to working on the front line on a COVID ward if you're a nurse. But if you're going back to work in a lower risk environment, that should be fine. So somebody's asked, Angela Peters has asked about medicines which reduce your T cells.
because they're massively reduced in people with COVID-19. So are people on drugs to reduce their T cells at any greater risk from coronavirus complications?
So I'm going to say no to that, and I'm going to say no to that because my colleagues in South Africa tell me that there does not seem to be an increased risk of bad COVID disease in people who have HIV, and HIV is the classic condition that reduces your T cells and increases you to the risk of infection. They were very worried because they have a huge population of HIV and AIDS people in South Africa because they had a denialist president for so long. They were very, very worried about what was going to happen with COVID. So they had a very fierce lockdown, but they have not seen any increase there, thankfully. And so I'm going to extrapolate and say no, but I don't know any more than that about drugs.
Okay. What about face masks in public for patients with IBD?
I mean, it's not.
Andrew Crozier.
Yeah, it's certainly not mandatory, but yeah, in confined spaces, I would certainly consider it. Public transport, busy supermarket aisles, I would certainly consider it especially if you were at vulnerable in terms of your risk category.
I think that's spot on, Janice. It's just remember what I said earlier. Where are you at risk? You're not at risk outside. Unless you stand like that with someone else and have a conversation. If you socially distance outside, particularly if you can move, if someone comes towards you, whatever, you're fine. If you're on a bus, in a tram, in a packed train in the future, or in a crowded office space or a supermarket or whatever, then I would say it's probably sensible.
2 or 3 people have asked very good questions about going back to school. So we don't know the answer yet, but probably if your child is not shielding, then they will be able to go back to school. So if they're on azathioprine or any other medicines which put them in the moderate risk, that should be fine. Why are we not, this is from Eileen Grant, excellent question. Why aren't we testing poo samples to see if there's COVID in them?
So we could test poo samples for COVID or the SARS-CoV-2 virus, and we can find it in people who have had the virus. We can find it after they've had it. We do not know whether or not that is important in terms of the effect it then has. Is it inert completely? Probably. Does it have the risk of causing an infection? I'm going to say probably not. We're not testing because I'm not sure we would know what to do with that information.
I think that's a fair point. And just before we wrap up, people always ask the most controversial questions at the end. We had one about cannabis in our last session on diet and IBD. Vitamin D, what's your opinion on vitamin D and its role here? And does it help people with IBD or with COVID-19?
Get out in the sunshine, get some natural vitamin D. I think actually vitamin D is important. There's quite a good evidence base around this now. You can't take it in massive doses to help you if you get COVID. Taking a low dose every day is probably not a bad idea. But the sun's shining, go out and get it naturally if you can. If you can't, if you're stuck inside shielding, you probably should take the vitamin D supplement. Okay,
and to the people who are asking, who are looking on the BSG website and can't find information for their children, there is shielding information on the BSPGHAN, sorry for the long acronym, but there is specific advice there for your child with regard to shielding and information specifically for patients. Listen, I'm really grateful to Charlie. I'm really grateful to Charlie and Janice for giving up their time tonight, particularly any night, but especially on a nice night like this. Please share the page. Please like the page. We will try and come back to you with general pieces of information to answer the questions we didn't have time for. But thank you very much for all your questions. Janice, Charlie, thank you for your input. It's been absolutely invaluable. I don't think we've had a session where we've had so many questions and not been able to answer them. So that's a reflection of the quality of what you have to say. So thank you. And everybody listen to Charlie's message. Take care and look after each other. Thank you very much. Bye-bye for now. Thank you.
Thanks. Bye-bye.
Thanks very much.
Good
They
stuff.
they were good questions.
Yeah.
Oh, I wonder what happened there.